And next time, I'll deadline.
Thanks, Linda. So in terms of process, then we'll have the board development section in February, where we'll devote that time to working through the IMTP, and obviously, importantly, for the next financial year, our plans for spending, our allocation, and looking at what opportunities perhaps sit there. And then the IMTP will come back to the board at the end of March at our next board meeting for final sign off. So, okay. Any questions to Linda on the work that's been done? No. Okay. Thank you very much. Item 6. So just a note report, and item 6.5, the primary care and community development update from Gethin. The reason I asked for this to be on the agenda was because we had the board development session in December, where we considered what our ambitions were around the future shape of primary care, but also within that, so community-based services. We talked, and Gethin's alluded earlier to the ambitions around the CTM hospital at home, the recruitment we've done around healthcare support workers to help people to leave hospital, and this is very much as part of that process, starting to think about what are the shape of those community-based services, which primary care is fundamentally important. As we shift things more away from our hospital environment, close to where people live. So it's part of a much bigger jigsaw, but I thought it was useful just to have a report for the board to highlight the work that's been undertaken. So thank you, Kevin.
Yeah, thanks, Chair. So you have the paper, and as John says, we this was part of the board development session, but I think it is important to recognise the complexity actually of what sits within the primary community bucket in terms of services, and as set out on in 2.2, this is we're talking about community nursing, community therapies, we're talking about our community hospital beds, we've got specialist palliative care services within there, we provide GP out of hours, we've got the navigation hub, and an element of these services, particularly in Bridgend, we deliver through an integrated health and social care service. So it is a complex system. The way in which we structure that is we look at it around first of all our 3 localities, which are aligned with the local authority footprint, and then they're subdivided within the cluster arrangements. So for example, in Bridgend we have 3 clusters that sit within there to bring together geographically located populations into sort of smaller planning subsets. And then sitting below that, of course, then is the individual practice populations. That does have a formal governance structure around it. So there is the cluster teams. They're supported by management resource, and they work through then those local cluster planning. I'll put my teeth into that, haven't I? Cluster planning groups come through then to the regional partnership board.
Localities.
So yes, so that is there. Just in terms then of those local planning groups, each of those are co-chaired either with the director of adult services for that locality and one of the executives from CTM. So for Bridgend, that's Claire Marchant and myself. For Merthyr, that's Lisa and Lauren, and in RCT it's Neil and Linda. So again, really trying to see that joined up sort of core leadership. We know, 2.4 outlines all the challenges that we're working with in terms of the population. We also know that our services are not joined up anywhere near as they need to be. Part of that is by history, part of that is commissioning decisions from the centre. And when we've had a little bit of money for a left toe service or a right knee service, we've ended up overlaying that rather than being clear there is a single team that provides that range of service to that population. And of course, we're working within quite a rigid structure around the primary care model for Wales, which again is a mandated model that we're working with. So We've done lots that we've already described. We've established a navigation hub. We've made that investment into the hospital at home model. We're using that population health management. We've got first contact practitioners working in practice. We've got the continual involvement of the WISE service, all of which are really important components. But the reality is they all still sit separately within that infrastructure. So the real purpose then of our primary care and community transformation board, that's chaired by Paul, is that we want to bring that together. We want to actually move towards, and we want to co-design this with colleagues in primary care, a delivery model that addresses that embeds the population health approach, supports the chronic disease management of patients within their communities, but that absolutely then also it completely interlinks with the rest of the health system. But it has to be about enabling us to shift care. And it's the point, Hayley, you raised. For stuff that you ought to be able to have as close to home as possible, we need to shift it to be delivered as close to home as possible. If you need specialist service, we need to be doing those in centres of excellence where we can really max out the ability, the capability of our specialists. And so this is absolutely about creating that service platform in which then we can move more services out of the hospital into the community and deliver those either in the patient's own home or as close to their own home as we can possibly make it. So we've engaged support from the National Association of Primary Care. We're working with us around this model, and over the course of the next 6 months, we'll be evolving that into a very clear delivery plan for how we move that way. So I'll finish there, but happy to take any questions.
Thanks, Catherine. Can I just say, I'll bring Phyllis in next. Can I just say, firstly, in terms of the work that's been done clearly at pace, bear in mind we've had I know discussions around this we've been having for some time, and certainly following the establishment of the board that Paul chairs. But having had the board development session in December, I know there's been further engagement work with staff and colleagues around how to start to shape this. I'm really pleased that the National Association of Primary Care is involved in this. As an organisation, they have delivered change in England at pace, recognising really good models that can work. So I think the fact that you're engaging them in this work is terrific, and I think bringing that expertise in to work with Paul and you and the team is absolutely the right thing to do. And a really ambitious timescale, that 6 month period to do those things and to get to the point at which we are looking at that implementation plan. Just as chair of the board, what I would like to see is for that to come back to the board when things are ready and we're able to do that and to fit it in, because I think again, this is demonstrating that significant shift that we are trying to create. This is not just about, however important it is, around the model and type of services that we deliver where and how within our big hospital sites, but how we improve access and outcomes and patient experience in a whole range of different ways, but also by improving population health, by getting into prevention agenda, utilising the amazing network of staff we have in a variety of different disciplines to meet people's needs more locally. I think this is exactly the sort of work that we need to be motoring on with in the course of the year, along with the other work that we're clearly doing as well. So great update. So Dilys and then Ian, thank you.
Yeah, I just want to give some feedback on the WISE service. I run the Rhondda Over 50s Forum and the I know it's unbelievable, isn't it? But yeah, the WISE service. The way getting up to me. The WISE service came in and talked to us about stroke prevention, gave us a big presentation on what contributes, etc. Took people's blood pressure, heart rates. They've gone to all 5 over 50 plus forums in Rhondda Cynon Taf, and in every forum they pick somebody up who needs further treatment. The one individual in my forum, if you looked at her, we'd spoken to her about her lifestyle, no way on earth was she going to be in danger of a stroke. She's thin, she eats healthily, she exercises regularly, has never smoked. But her blood pressure was so high, she was immediately sent to the GP. Turns out she has a hereditary condition. Her father had dropped dead at age 49. And if she hadn't gone to that session, she may well have gone the way her father did. And she actually rang me and said, thank you for saving my life. because when she spoke to her GP and the GP had done all the tests, and she's now having regular monitoring on the proper medication, etc. So that's just positive feedback on how well the WISE service is working. They came to speak to us about stroke prevention. We're the age group probably that they needed to speak to about. And in every single forum, somebody was picked up and is now having the treatment and hopefully will never be in a stroke bed.
Yeah.
That was it. Really.
So thanks to this. Ian and then Patsy.
Yeah, I think it's great to see this focus on primary care. One thing I raised this in the operational committee, I think it was a few days ago, isn't it? About dental, and it really does worry me about dental, and maybe Gether or somebody could come in and explain how dental fits into all of this. We know there's a massive waiting list in dental, and I think in our committee I said dental is almost like we see in the inverse care law applied to dentistry, because you go in poor communities like Cairo, for example. Most of them haven't got a dentist, and the state of their teeth is dire. So how do we sort of integrate all this into this primary care work that we're doing?
Well, you're absolutely right, and there's a lot of evidence that says in children, poor oral health is a good indicator of future health issues. So, as you rightly say, Ian, we've got a big challenge in our communities with dental poor oral health. And Philip knows and others, we've had conversations as an exec team. We still have children under 10 going to hospital to have all their teeth taken out. Which feels in this day and age is pretty terrible, isn't it? And you could argue that we should collectively be treating that almost like a never event, to say, well, if that's happened, we need to really understand why is that, have we allowed that to get to that place where that situation's occurred. Part of the challenge, as you rightly say, Ian, is capacity. And what I would say, we're actually well placed nationally. Julie Denley, Gethin's Deputy for Community and Primary Care, sits on the dental national contract conversations, and Rob, our dental director, is also heavily involved in the national dental contractual negotiation. Some of this candidly is tied up in the market. We talk, dentistry is a challenge at the moment everywhere in terms of recruitment of dentists. That's a problem. And there are also contractual challenges in terms of the way the contract's constructed, which is not always incentivising dentists to take on NHS work. But I guess we might want to add to.
Yeah, and just in addition, Ian, and I referenced this in AGC as well. We are working through the service to look at what more could we be a provider of in terms of general dental services, recognising the market is there. In some areas the market's buoyant, in other areas the market doesn't exist, and so what we're looking at is what further options are there for us to provide to be the core provider of services in some of those areas. So a lot of work to do, but there is a proposal coming from service.
And we can't forget the prevention element of this in progress like design to smile. I'll share the data that came through yesterday. We have seen a reduction in prevalence of tooth decay and the number of teeth, the severity of decay as well, compared to the Welsh average. But clearly there's a lot of work to do. And I mean, as I say, the focus should be on the preventative side, and very much as the treatment side.
Sorry. Where's my list? Sorry. Patsy and then Linda. Sorry, Patsy.
That's okay. Oh, sorry, excuse me. Obviously, I mean, this is excellent and just what we need to get the services. But my question's around the risk of over medicalising some patients because of the detox situation. So we can't get them into social care. We can't provide social care because it's a whole different regulatory body. Are we at risk of wanting so desperately to discharge some people that we're putting them into a hospital at home situation as opposed to waiting for social care? I'm not saying we are, I'm saying, is there a risk there?
Dom, and then I suspect Gethin might want to.
The risk is greater keeping them in a hospital where they become institutionalised, and the debilitation, the effect of not being up and about and moving about in your own home and just being on a ward where food is brought to you, where David wants them to get out and walk around to, we cannot underestimate the impact that that has, and that is probably the worst outcome we can have for our patients to sit in an acute hospital bed. The next one down would be a at-home social package. Best one would be managing at home with a proper social package at home, and then the halfway house in between. So if you grade it like that, it's not great, but it's better than the alternative of sitting in an acute place where they're debilitating day by day.
Oh yeah, it's
Sorry, bring someone else in.
Yeah, definitely. I can't think of the numbers, but it's sort of, you know, for every week that you're in a hospital bed, you'll lose muscle mass by what, 7% or something like that. So we really need to get them up and out ASAP.
I'm really just wondering if there's a risk of using the capacity for something as good as this is, just to solve another problem that is a, you know, sort of a really difficult problem to solve. That really.
Fundamentally, I think it's about trying to get a system in place that maximises the health benefits to an individual at the right point. And so much of what we do, despite it being, I think, quite brilliant throughout our health and social care system, but very often people are accessing things in the wrong way, and sometimes too late, and sometimes it's being done in a way that doesn't maximise their health outcome. So it is about using resources differently as well. Getting
Yeah, so two points, I guess, Patsy, and it's a good challenge. The first is we know we overprescribe in health, social care, and when we get patients into the social care system, it's really difficult then to take them back out. And when you assess Mrs. Jones in a gown in a big environment where she's not had sleep, if you're asking her to walk a space that just doesn't exist in her own home, they're all tests that we're going to end up going, crikey, we don't know when they're in hospital how they cope at home. And so I think the fundamental purpose of a hospital at home is actually to give everyone the greatest opportunity to get home and to live independently. And I think that is an important part of their health pathway, and that we can take patients out earlier than we probably would if they were just going out for a standalone package of care. So that allows us, I think, to right size packages, and we know probably 20 to 30% of the people we refer in 6 to 8 weeks' time won't need a package of care. The other important bit, though, is also about admission avoidance. So we know we admit lots and lots of people to our hospitals every day who we admit, and they don't have an acute medical need to be admitted, but whatever condition they've got is meaning that they're struggling to cope at home. And a big part of the ECC service is about putting in that rapid response and being able to put wraparound care in place for that patient for a week, for 2 weeks, maybe 3 weeks, whilst the antibiotics kick in, whilst we can support them. But it is about, it's not just about providing that care, it's also about making sure the OTs are doing some of that assessment about how their home environment works and all of those things. And I think that's our responsibility. So I think it is a blend, and hence why we're delivering it in partnership with local authorities, but it is about trying to make sure that we manage what we can do to manage demand on local authorities is done appropriately.
Linda.
Yes, mine's a question to the board about our patient story. It strikes me that we don't just serve patients, we serve the population, and I wonder whether we might also be thinking about stories from people that have been part of programs where we've done preventative work or coordinated primary social care type activities, and how that's made a difference. It's just a question of whether that would be something we should explore.
We should, thank you, Linda. Kath.
Well, it absolutely segues into what I was going to say as well, in terms of how do we measure success from this programme and what are our KPIs, etc. But also having the stories as well. I think Linda would be absolutely fantastic. I just want to say how impressed I've been at the changes that we've made just in the last year around this. I think it's been absolutely fantastic, and the direction of travel is just brilliant. At strategy committee, we did talk about this quite a lot as well, and we had a detailed paper. The one thing that I think really struck me was, which I know is in this paper, is around the palliative end of life care and how important that is, and the improvements that we need to make. And I just wanted to mention that because I know it's in the paper, but it is a really important part of it, isn't it? That particularly when you look at CTM's figures around the number of people dying in the hospital rather than at home. So I just think that's just something I just wanted to point out as well. But no, massive thank you to the team. It's really great.
I think Hayley wants.
Sorry, Hayley, do you want to come back
It
in?
was just going to be in response to Linda, really, just from that sort of preventative work, either sort of like the WISE team or the SHIV teams in community.
My teams do a whole load of work in this area, and
Like
they're
with-
gagging to come and tell you about it. So.
Yeah.
Well, Linda,
No,
let's
that
let's
again.
make that happen until we can. Lauren, please.
Yeah, so great to see how much work and how much enthusiasm there is in our teams to do this. I guess just building on Linda's point about language and patient story or not, and coming back to you, Patsy, around the over medicalised. I think terms like hospital at home and virtual wards of national language is very medicalised anyway, isn't it? So again, I know you referred to enhanced community care, so it's just I think the language that we use comes with, you know, people have certain expectations around that, don't they? But you know, in terms of the model, it's definitely about supporting people back into the community and limiting that medicalisation.
Likewise, with social prescribing, it sounds like a medical intervention.
Yeah.
It's absolutely the opposite.
Yeah.
But you kind of run the risk then of, you know, if you're prescribed medication, people are absolutely going to take it. If you go and have a walk around the block, they'll be like, well, I might take that advice, but I might not. So if you're prescribing, I need to do.
Okay, so Paul, I'll come back to you next. There are some next steps that are so the recommendation of the board is we note the update, but there are some next steps around developing with the National Association for Primary Care plan, the key stages, time frames involved in developing the strategy, which is great to see. But Paul, I'll come back to you. Thanks.
Yeah, so I suppose I agree with everything we said. We are making some really big inroads now on this agenda, some really good progress. But I'm really honest, I think we need to do more. And if you reflect on the agenda of our conversations today, I would suggest 90% of what we've talked about has been about hospitals.
Yes.
And we've done a paper at the end, 10% probably on primary community, which is great. But if we're really serious about this agenda driving everything that we do, it's got to be much, much more writ large across everything that we're talking about. So just I guess a collective challenge, Justin, John, you know, we've had that conversation, haven't we? But adding it back to your point, Kath, about how do we measure impact on this? Well, one of the ways we measure impact on it is how much are we spending on primary and community services versus what we're currently spending on hospitals. And this isn't just us, it is a national problem, is that more and more and more and more money just gets poured more and more and more into hospital services, dealing with the symptom, not the cause. So I think we need to think about moving forward, aligned to our strategy work. How do we start to articulate a different model of resource allocation over a number of years that we could say in 5 years' time, look, we were there and now we're here. And that's a really good metric. I know it's not the only metric, but it is a key demonstrator of our commitment to this agenda. Second thing I'd say is this whole model relies on primary care being sustainable and secure. And we've touched a little bit on it earlier on about the conversations on accessing primary care. Primary care model currently as it stands is really, really fragile, not just here, but across the UK. And all of our ambitions and aspirations for this agenda will fall by the wayside if GP practices just collapse around us, because everyone will end up just coming in an ambulance to a hospital and it will just end up getting worse and worse and worse. So whilst we talk a lot about the sort of general ambitions around primary community services, I do think it would be a benefit at some point to have a conversation as a board about the fragility of primary care itself and some of the things we're talking about doing with our colleagues in primary care to try and support and develop them, because candidly the model we have at the moment is not going to survive in the next 5 years, and we can all sit and watch it collapse around us, or we can be proactive and get involved and start to think, well, what could we collectively be doing to try and support primary care? Dom and I were at GP forum last week with all the GPs, and you know there is such a level of worry And so when you stand up and talk about, oh, well, we're going to do all this stuff, they all look at you as if to say, are you mad? When are we doing that in the 5 minutes at the end of our day? We haven't got any time to do anything extra. So I think we've got to be really careful that we don't get really excited about what we could do without addressing the core fundamental capacity problem that is, what are we going to do in the primary care system just on GPs? I know there's issues in dentistry, there's issues in pharmacy, but the reality is the GP model currently is not functioning as we need it to function if we are going to do all the things that we want to do in terms of moving care close to people's homes. And I absolutely agree with you, Patsy. If you walk down any of our high streets today and say to people, what's the biggest issue with the NHS? I guarantee they would all say, can't get an appointment with GP. More so than I'm on a waiting list for an orthopaedic operation or I'm waiting for a diagnostic test. And I've raised that. I've got now the lead chief exec role for primary care, and I've raised it. And I've been quite surprised nationally how people say, oh, we've got a problem with access. Like, well, you haven't got a problem with access. You're just counting the people who've managed to get through on the phone. What about all the people who gave up and didn't try, or went to A&E, or have just sat at home and ignored symptoms because they think, oh, I won't be able to get an appointment. So I think there is something for us about just in this work, which is what we're absolutely doing with NAPC. And the advantage of someone like NAPC coming in to help us is they've got experience of looking at where people have cracked that problem and access and how they've dealt with that. So I think we've got a real opportunity through this work just to look at. And so I don't want to. I'm not trying to, put a down on it because I'm really, really committed to it. But I think we've got to be really open eyes and realistic about going into this, about the scale of what we're dealing with. And I think we need to have more of those conversations here. And I do think there's something about how we get the GP voice into this table as well, because the GPs around us, frankly, look at the house board as this distant remote thing that just pays their contractual value. And I think we've got to do more to bring them more into the agenda and get them to help own it, but also play back to us the challenges we will have in terms of moving it forward.
I think they want that too.
And we'll give us some thoughts on. I think it is one of the deficiencies in how boards are structured. That when you look at where people access services and where the bulk of people access services locally through their GP network compared to those people who end up in hospital, and look at the resource profile, which is overwhelmingly in our hospitals versus the minority of what is spent locally, and yet for the bulk of the population, those experiences around primary care, the experiences of our GPs are difficult to articulate, despite the fact that Kath, as vice chair, does a fantastic job in leading on primary care and community care. From the professional perspective in general practice, that is something that is a deficiency. So, I mean, if there's an opportunity of including somebody from general practice in our board discussions, I mean, we have the ability, I believe, to bring in additional, I don't call associate members, but there's like co-opted members, but then maybe that is something that we need to look at. I mean, as we're going to be going through this program of work with the National Association of Primary Care, and where things will come back to the board for further discussion and presumably approval, I think it would be certainly in the short term, at the very least in the short term, perhaps a bit longer, having somebody from primary care to work with us at board level, I think would be the appropriate thing to do if that's something.
I think
I think that's a great idea.
Okay,
Totally
we'll
endorse that.
take that forward.
Yeah.
Okay, so thanks, Paul, and thanks to the team for the updates in what is a really, really vital part of what we do. And Paul's reference earlier to the spend profile. There are countries elsewhere in the European Union that spend a higher proportion of their budget on services outside of the hospital environment. It is just where we are as a country and what we've developed in the last 75 years plus, where the focus has always been on doing more and more in bigger and bigger very expensive hospital environments. So that's just been the direction of travel since the inception of the NHS, whereas other countries have taken more of a proactive approach in shifting that spend profile more towards where people are actually more people are accessing more of their services, which is locally and closer to where they live. And as a board, and as we look at this work and we figure out through that implementation plan, what does this really physically mean for us? Then I think we ought to be considering how that spend profile changes. What does that mean for us over the next 5 to 10 years? And do we get to a point at which we are spending proportionally more of our budget on delivering those services out of hospital? Now, I don't know what that would look like in terms of percentages. At this point, I'm more about the principle of whether that is something that should be part of our thinking, because if we are really ambitious about ensuring that people have more near where they live, then the resources in all its different guise, not just managing our estates, not just our workforce, not just money, but certainly technology and as well, that will all need to shift in quite an ambitious way. So that will necessitate us looking at how those resources are spent. I think we should come back to that. Okay, thank you all very much. Item 7 on the agenda, strategic planning. We were going to have a discussion around the business case for digital cellular pathology, but that's been postponed to the meeting at the end of March. Just looking at the consent agenda under item 8, can I just ask the board to approve those items listed 8.1 down to 8.1.5, and in addition to that 8.1.7, colleagues happy to approve those items. Thank you. And in respect of item 8.1.6, it's the Joint Commissioning Committee's governance framework. There is a paper that needs to be approved by boards, but there's been some difficulty in the wording of the paper. Gareth's going to explain what it is, and there's a way of us handling it. But so that's something more cloak and dagger than actually. But having introduced that one very badly, I'll hand over to Gareth.
Where is now? This is going to be such an issue, right? Okay, yeah, thanks, John. I briefed you yesterday on this.
More clarity than clarity. So there we are.
So yeah, so we are still asking the board to approve item 8.1.6. The version of the paper that was approved at the JCC around the governance framework included a reference to staff side representatives attending the subcommittees of the JCC, the one on quality, safety and outcomes and the one on planning, performance and finance. That isn't actually something the JCC is pursuing. So we've talked to the other health boards. The other health boards have either met yesterday or today. So they are also approving this paper on the proviso that that reference to staff side representatives is taken out on the paper.
So the board is being asked to approve the governance framework, where we will also, well, the JCC will remove the reference to the staff side being included in those two subgroups, because obviously they don't have any staff.
Yeah. So
yeah, so it's just for clarification. Otherwise, we'd be approving a report that was containing something that couldn't be delivered.
Thanks, Chair.
Okay, you're happy to approve. Thank you very much. Just on items 8.2 through to 8.2.5, just to note those items on the consent agenda. I don't believe there's any other business today. Just to remind the board that once we've concluded the public board session, there is a quick conversation, a quick discussion in private for the board around our financial plan for next year. Just a couple of things we wanted to touch on before we return to all of that as part of our board development session in February. But apart from that, there's no other business to discharge today. In terms of meeting feedback, again, in terms of improving how these meetings work, if colleagues can within the next 2 weeks provide any feedback as to how today's board meeting has gone, that would be very helpful. Always keen to evaluate how the sessions run. There are no items requiring in-committee discussion today, and just to inform the board that the date of the next public board meeting will be on the 27th of March. But obviously before that, as I said, we have the board development session, which we're holding at the Princess of Wales Hospital in Bridgend. Rydyn dod y cyfarfod o boddiad i ben, a hofyn diolch y fawr sydd wedi ymuno yn ei gwirionedd gyfarfod heddiw. So now bring the public board meeting to a close, and would like to extend thanks to all those who participated in the meeting and those who have observed our proceedings virtually. Thank you all very much. Thank you.